Welcome, everybody, to this session by one of our previous graduates, Dr. Monica Riley. Monica is going to be presenting to us on effective trauma-informed care that improves the psychological well-being of female inmates. And I invite you to comment and ask questions in the chat. We will hold them to the end and have a brief discussion then if time allows. Monica, let me turn it over to you.
Well, good morning, everyone. Thank you for joining. So yes, my name is Dr. Monica Riley. I'm still trying to get used to it. And I am a recent graduate, and I'm going to be talking about my project, which was effective trauma-informed care that improves the psychological well-being of female inmates. Next slide, please. So trauma-informed care is basically an approach that is currently used to ask what happened to you rather than what's wrong with you. So for many of you who understand the criminal justice system, when individuals are introduced to the criminal justice system, it's always about what's wrong with you, why are you acting the way you're acting? Well, my project focused more on female inmates, as there were very minimal studies about female inmates with histories of trauma who were introduced to the criminal justice system. So for my project justification, I focused, like I said, on female inmates ages 18 years or older. The type of history of trauma was not specified. So I just moved forward from there. Originally, my focus was on domestic violence victim survivors who went to jail for either killing or harming their abuser. So with women offenders, they often experience a diverse series of trauma before and after incarceration. Out of the 98% of incarcerated individuals who have disclosed their history of trauma, 86% of them are women. The traumatic experiences significantly influence their mental health and leads to conditions such as anxiety, depression, disassociation, and symptoms have a long-lasting effect on their psychological, emotional, and physical well-being. So once they enter the prison system, women are often faced with even more challenges, leading to their effects on the psychological well-being and also their maladjustment. So what happens is when individuals are incarcerated, they are experienced with a lot of emotions, obviously, because of just what happened. But also as they go in, there's a good possibility of triggers, which often without even knowing whether it could be a smell, a color, a facial expression, those women react to those triggers. And then once misbehave, are often asked, what's wrong with you? Never asking what happened to you. Next slide, please. So the purpose of my study, again, was I wanted to examine which trauma-informed care approach would best be suited to increase and be effective on the emotional well-being and psychological well-being of female inmates, enhancing their self-efficacy while improving their psychological, emotional, and physical well-being. The interactions between the Department of Correction and female inmates can either foster stability or exacerbate the dysregulation of maladjustment, which highlights the importance and the need for the psychology and Department of Corrections to work together. Next slide, please. So my research questions were which trauma-informed care approach, components, and strategies are most effective or show the most promise for incarcerated women to develop positive coping skills and improve their self-efficacy and improve their psychological well-being. My second question is, what are the resulting recommendations for incorporating trauma-informed care components and strategies into correctional settings to develop positive coping skills, enhance self-efficacy, and improve their overall psychological well-being of incarcerated women? Next, please. So my framework. So the frameworks that I chose obviously were the trauma-informed care approach, but I also broke it down a little bit more to trauma-informed care approach, the guiding principles for incarcerated individuals. So the principles of trauma-informed care within the organization are to understand the life situations of individuals, their past and present, to provide effective services and limiting the revictimization of individuals. So the guiding principles of trauma-informed care, like I said, are broken down into 5 fundamental principles. The first one being safety, trustworthiness, empower, choice, collaboration, mutuality, voice and choice, cultural, historical, and gender sensitivity, and trauma awareness and understanding. So because of the success of trauma-informed care, like I said, it's been expanded to 6 principles for individuals who have been incarcerated. So the first one, obviously, safety and supportive environment, trauma-specific therapy, gender-responsive programming, mental health and substance abuse treatment, peer-to-peer support group, and group therapy and skill building. Next slide, please. So I wanted to incorporate Albert Bandura's self-efficacy theory and Albert Ellis's rational emotive behavioral therapy. So self-efficacy theory, as you can see, I built a little scale and I don't know where it went. There it is. So it has 4 components: experience, vicarious experience, social presentation, and psychological feedback, which all stems into self-efficacy, which then leads into how we behave and perform. For Albert Ellis's rational emotive behavioral therapy is broken down into A, B, C, D, E, and F, which are his key principles. And basically, in essence, with REBT, all it is taking your negative, irrational thought and redirecting it to your positive, rational thought. So this helps individuals, specifically incarcerated individuals, to retrain their brain to where practice becomes a habit and you go from your irregular, irrational thought to your regular, rational thought. Okay, next slide, please. So my methodology and data analysis, I focused on the history of trauma, psychological well-being and self-efficacy, and trauma-informed care. As you can see, what I did was I used in my SLR, I used the Prisma chart and I focused on research of trauma-informed care and criminology in the United States. I focused more on the history of trauma and how they got to the incarceration. And basically what I found out was most of my research led to childhood trauma, which in turn is individuals who get in trouble or react in their youth, never receiving assistance or therapeutic services, which leads them into their adulthood and experience criminology. Many women, especially, have a history of domestic violence, sexual assault, and sexual abuse, which was never treated as well. So I used everything, all my research came from the university's library and broken down into subcategories, as you can see in my chart. I feel like I'm running out of time. I apologize. Okay, next slide, please. So my findings, like I said, I included the history of trauma, their psychological well-being, self-efficacy, and trauma-informed care. And I emphasized on the significant importance, specifically in the history of trauma among female inmates. And as I stated, significant articles covered the history of trauma, mainly sexual abuse and domestic violence and sexual assault during childhood, which in the symptoms, both physical and psychological, increased into their adulthood. The correctional facilities were not equipped to handle these types of psychological and physical triggers. And so it's very important to understand and how to incorporate trauma-informed care approach programs in the correctional facility in order to address not only the physical symptoms, but psychological symptoms as well. Many women are faced with emotional deficits because of their past trauma, and it's very easily within the Department of Corrections to re-traumatize these women and not understanding why it is that they're acting. Specifically, we need to train the correctional staff and administration, whether civilians, which are individuals such as nurses or front desk, all the way up to correctional facility sworn officers. And next slide, please. So the recommendations for my research are to build a relationship between psychology and the Department of Corrections in order to put together satisfactory groups in order to limit the triggers and revictimizations of incarcerated individuals, specifically women. Many women are going into a correctional facility and not understanding their emotions, and often looked at as whether it's their time of the month or they're just being dramatic, whereas men, they don't express their emotions such as increased as women. So what happens is, in order for us to incorporate trauma-informed care approach with the Department of Corrections, it needs to be properly trained and introduced where the officers and administration understand the vital and critical use of trauma-informed care, whether it is with therapeutic services or on just a general daily basis as to why someone may be acting out. And next slide, please. Oh, that's it. So my chair loved to send me quotes during my journey in my ADP project. So I found this quote that I absolutely adore, and it says, "Trauma is a fact of life. It does not, however, have to be a life sentence." And
That is a very fitting conclusion. I thank you so much for presenting your research. It's fascinating research, and I have some questions, but I'd like to open it up first to our audience members if you have some questions or comments. And I will tell you, Dr. Riley, that you're getting some congratulations in the chat. I know it's been 6 months approximately since you've been Dr. Riley, and something like that.
Yeah, 4.5 months.
Yeah. So it takes a while to get used to that.
Sorry, I've been nervous.
So one of the questions from the chat, again, starting off with a compliment, excellent presentation, Dr. Riley. Did you encounter any proactive approaches to mitigating sensory triggers in the prison systems? This is from Dr. Dana Dillard.
I have not. Are you asking for anything specific?
Well, it's not specifying anything specific, but in reading your work, I'm not sure that I recall coming across anything like that, but I know this is an area of interest to you, so I know that you're probably continually reading and researching this. So those sensory triggers, you started out your presentation talking about, like a sound or a color or something like that. Is that something that does the literature spend very much time talking about those kinds of issues, or is that something, I know you've worked in this area, so you've observed things as well. So you have two different sets of knowledge about this topic.
Yes. So unfortunately, the research does not address any sensory triggers because it's still a brand new field and approach per se, that they can't, individuals who don't understand a trauma-informed approach, they don't see a correlation between an external trigger and an internal trigger. So basically, if let's say someone who is a survivor of domestic violence and, their partner's favorite color was orange. And so that individual who is the victim survivor correlates orange with their, abuser. And so even walking down the street, if they see like something orange, they'll go into either what they consider to be a panic attack or anxiety attack or, heart attack most times. But as far as studies go, there has been no one who can actually pinpoint the correlation between an external and internal trigger. That it's so important that there is future studies on trauma-informed care. Now, as far as what I have observed personally, it's very, very common in the Department of Corrections, specifically when they are considered to misbehave and put in solitary confinement, or as my inmates call it, the hole, because of the fact that you are confined to a single area. And then obviously you're in your thoughts and there's nobody there to provide you any like guidance or assistance in order to get over that trigger.
Okay, so it sounds like you're recommending that it would be great if there were some sort of proactive approach, some tools and things that we could give individuals in those situations to be able to better manage and cope with those kinds of things.
Absolutely. One of the things that I work with my current inmates is to guide them in recognizing their triggers. So that way we can put together a treatment plan. So as we move forward, it's easier for them to recognize their triggers, take a step back, and redirect their thought.
Excellent. And Dr. Dillard says, thank you for your thoughts and your recommendations. And we have another question from Christina Riggs. Christina says, coming from a military work center, we have a vast variety of individuals who have past experiences, little t and big T. Research alludes to needing to be trauma-informed care, but in execution, it is harder to do so when the workspace is historically a suck it up, get help, and do your job. Have you come across behaviors or methods of being supportive, but not coming off as too soft?
Yes, absolutely. That's why I'm such a big fan of rational emotive behavioral therapy, because especially just like the military, the Department of Corrections is the same when it comes to female corrections officers. And one of the things that I always, talk to them about, because of course I just don't help the inmates, is how to redirect our thoughts and be able to handle our own emotional and physical reactions. Very important, specifically when you recognize your own reaction, even though your external environment may not be trauma informed per se. If you can internally be trauma informed and recognize those triggers and be able to talk yourself down and recognize them, it will be very beneficial. So that way people don't see your reaction, they'll see your action. I hope that answers your question.
I think it does. I hope it does, Christina. I will say I really love this is a very empowering presentation that you're giving here and the recommendations and your considerations.
Thank you. I'm very passionate about this.
You are. Well, that leads into, I don't see any other questions right now, so I'll ask my question, and that is, how have you used what you learned through this research experience? How are you using it today as Dr. Riley? How has this carried you into your career?
So, thank you for asking. I've been with the Department of Corrections for many, many years. Currently, in order to complete my psychological fellowship, I am working with seriously mentally ill and seriously mentally ill sex offenders who are on lifetime supervision. Now, for many of you who know me, I prefer to be with murderers rather than sex offenders. But being that I am unbiased and very professional and I love what I do, I currently am expanding on trainings in REBT and trauma-informed care. I'm also giving trainings on trauma-informed care to administration who's working with this demographic and have never been involved in the criminal justice system. So I practice, like I said, with my clients, patients, how to find their triggers, recognize their triggers, and practice redirection in order to limit the, I guess, to limit their ability to reoffend, specifically because many of my lifetime sex offenders are charged with crimes for children 14 years or younger. So it's very important for me to be able to practice REBT with them in order for them to redirect their triggers and their vices rather than their thoughts and emotions.
Interesting. Thank
I
you for
hope that
sharing that.
helps.
It does. It does. Other thoughts or questions from the audience?
I just wanted to say that was such a great presentation. That
Thank
was
you. I was so
it
nervous.
was a heart-wrenching but very interesting topic. The statistics are not surprising, but hearing that, I think you said 87%,
Was
something close to that, it's not, that does not shock me, but it's hard to hear. And I think that this is incredible work that you're doing.
Thank you. So those statistics were actually during my ADP journey. Unfortunately, the numbers have increased.
Very
Michael.
nice compliment from Dr. Michael Robinson.
Thank you, Dr. Robinson.
Well, I appreciate you sharing this, and I will encourage our audience members who want to learn more about this. Dr. Riley's ADP is published and available for reading, and she did a wonderful job. So I would encourage folks to check that out. Or I'm certain that she accepts emails from folks who are interested and curious.
Absolutely. Thank you so much.
Yes, and I saw Flory, I saw you just came on. I don't know if you came on video on purpose because you had a question or no, maybe not.
No, I'm sorry about that.
That's okay. Did you have it? Did you have any questions or no?
Nope, this was fantastic. Thank you guys so much.
Excellent, excellent.
Thank you.
And Christina, that is a great question. If you email me, I can send you the link. So my email address is just stephanie.stubbs@uagc.edu, and I would be happy to share that with you. And I see that Jackie just posted in the chat the TLC conference evaluation, so be sure to fill that out. And thank you again, Dr. Riley, for sharing with us. I echo Michael's sentiments. It's been a joy to watch you grow through this journey and to see the difference that you are making and how you are really capitalizing on that practitioner-based project approach and making a difference with your research in your everyday life. I think that is such a wonderful thing to see. So
thank you so much for this opportunity, and I will always be grateful to you, AGC.
Wonderful. Well, with that, I think we can end the recording and end the session and on to other presentations.